Good afternoon, good morning, and good evening. I wonder why I always say good afternoon first instead of saying good morning, good afternoon, and good evening. I guess it's because of where I am in the world. Welcome to our webinar today, and I'm very glad to have all of you on. It's always a pleasure to welcome you. Today, we're going to be looking at testing, what actually goes on, the bullseye in terms of how do we do a proper test? What are the requirements for doing a proper test? Again, my name is Kilian Songwe. I am the president at the Global Healthcare Public Foundation and its chief scientific officer. A Global Healthcare Public Foundation has been around for over the last 18 years, and we are predominantly in the space of standards, and it's all standards. It's management system standards, and helping organizations to be able to develop some of these standards, implement them, and be able to be good standing organizations. So it's all about testing. What actually goes on in testing, in the actual testing, in a wet laboratory, as opposed to a non-wet lab. So just to go in, just a few days ago, The Guardian put out this big headline article. It said, experts sound alarm over lack of COVID-19 test kits for Africa. And that's something that we've been looking at, we've been addressing in the last couple of days. And in one of the webinars we had, we actually spoke about the consortium of UN bodies and other private institutions that have come together to be able to alleviate this problem for the African continent. So the alarm is a real alarm, and it's one that we have to work with. Africa CDC has put this out. It says test, trace, and treat. This is a partnership to accelerate the COVID-19 testing. It's called PACT in Africa. And through the PACT program, basically what Africa CDC is trying to do is actually a leader in the consortium to be able to get test kits onto the African continent, to be able to help the governments to be able to test, of course, trace people who have been in contact with positive, COVID positive suspects, and then to treat them. So this is a really important heading as we go into looking at our bullseye here today. So basically, when it comes to testing, there are actually just two kinds of tests. And I know the two kinds of tests come with very many different names, but in principle, there are only two different kinds of tests. There is a viral test, and then there is an antibody test. And the viral test, predominantly, we've come to hear of PCR so many times, polymerase chain reaction. Basically, what it does, it detects the viral RNA in the person in real time. So the viral test is a very important test in determining that somebody actually is carrying the virus for the coronavirus and is positive. And then on the other hand, the second bodies of tests that actually exist are the serological testing, which actually uses blood samples. If I may, the viral test uses swabs, which actually is put in through the nostril or in the back of the mouth, oropharyngeal or nasopharyngeal swabs. There is testing that is going on now that says that we might also be able to use saliva for part of our testing for the virus, which is great. But also on the antibody testing, basically using blood samples to be able to do this test. Literally, you could get a blood sample which has even distribution from any part of the body to conduct the test. What is key to know as we go into talking about testing and trying to zero down to the efficiency and efficacy that is involved in testing is to note the emergency use authorization. The SARS-CoV-2 virus is new. Yes, it was announced made a pandemic in March, but it's new. And so as a result, there's not been enough testing out there to be able to come up with a determined test kit that we can say for certainty that all positive results shall be positive and all negative results are actually negative. So the emergency use authorization is actually given by the FDA and CE to allow manufacturers to produce kits that can be used for testing the virus and at the same time continue to gather information that allows us to come up with a very strong sensitivity and specificity of the test kits that are used. So as we go into testing, I'm just looking at what has happened in the testing arena, given different countries. And we're just looking at testing per million population. And we can see clearly that the testing has not scaled up as fast as we would have liked to see it scale up. We're thinking if you took this and you put it against Ireland or Italy, or even Italy, back in when the virus first got to Italy, Italy was testing 37,000 people per 100,000 population. So when you take a comparison like that and you put it on the African continent, we have Mauritius that is doing a very 11 tests per 100,000 people. But again, that's still a small test. But as the testing began to rank up on the African continent, we also began to see an exponential result of positive patients or positive suspects. So it is very clear that the more testing we do, the more positives we're going to get. But it's also important to note that we're not just going to test for sick people or people who are symptomatic. We have to test generally to be able to come up with the right proportion of positive patients to positive suspects to negative suspects. So there has been a lot of talk about flattening of the curve, and what does it actually do? Because everybody is talking about flattening of the curve, but what is it actually going to do to any country as you flatten the curve? What is important to note about flattening the curve is as we go through the period where testing kits are a huge problem, we want to be able to rank up with the test kits that we have as much testing as possible. Basically, what that is going to do for our systems is the fact that it is going to allow our systems to still identify the same number of positive people, but identify them over a longer period. What that would do is it's going to be able to have a lesser stress effect on our healthcare system. So instead of the hospital planning to have 500 beds to have COVID-19 patients at once, it may be able to have 150 beds, but have 150 beds over 6 months. So in essence, flattening the curve actually reduces the stress on the healthcare systems to be able to manage the pandemic and to be able to ensure the healthcare of the people. So as we go into testing, with all of this background behind us, there is a standard that is used. There is a standard that is used for medical laboratory testing. And the standard is actually based on the management system groups of standards. And talking about the management system groups of standards, there is the ISO 9001 for quality management. And then there is the ISO 15189 that addresses medical laboratory testing, in vitro medical laboratory testing. So I throw in this picture here because there is none of us who is watching this webinar now who has not seen a plane flying. And when you look at a plane this size, this is a Boeing 737. A Boeing 737 takes anywhere between 180 to 223 passengers. And when you look at the picture, it says at the top, result of a 1% error. Because of a 1% error, this plane never made it into the sky. So you have 238 people, passengers on the plane, whose life instantly is at risk. And this is very important to keep in the back of your mind as we go through the webinar, because I want to show you the impact of a 1% error on a testing that happens with hundreds of thousands of suspects that are being tested in any country on any day. So we have countries that are now doing testing from 500 suspects a day all the way to 10,000 or 10,000 suspects a day. That's a huge amount of testing to be doing on any one day. And for 1% error, that is actually 100% error to whichever suspect actually received a result with low sensitivity or a result with high specificity. So that is going to be very important to note. So I did mention the ISO 9001 basically has a very simple structure. It talks about quality management systems, quality systems, the quality assurances that are required, the quality control that is intended to be put, and then an inspection of the system. This standard is actually taken And when you think about that standard, we're thinking about people, we're thinking about equipment, we're thinking about the environment, we're thinking about methods, measurement, traceabilities. So basically there is an input. And this input is actually, if we think about what is going on in our laboratories, is a sample which has to be collected. There is a bunch of activities that actually go on. And that bunch of activity actually happens in what we call the examination phase. And when we go past the examination phase, then we go to the result phase, which is actually the output. So when you look at 9001, you have an input, which is a pre-examination phase, preparing the patient, collecting the sample. There's an examination process, which is actually the path of workflow. And then there is an output, which is usually the result. So talking about the ISO 15189 for medical laboratories, this is a specific standard that is out by the International Organization for Standardization. This standard was specifically put out for medical laboratories for in vitro use. This standard was actually built on the current ISO 17025 standard. And the ISO 17025 standard was used for calibration labs, and 15189 was built out of that standard to be able to allow our regular clinical labs and diagnostic laboratories to be able to have a standard which is understood and accepted by one and by all everywhere in the world, so that if you had results from any country and you say those results were run in a laboratory that was accredited to ISO 15189, then those results are recognized anywhere, anytime. And so on the backdrop of ISO 15189, I now want to look at the things that we need to have into consideration as we do the COVID-19 testing. Again, this is a repeat of some of the things I said between ISO 9000, the quality management systems standard, ISO 9001, the special requirements, 17025, the calibration laboratory standard, and then 15189 for medical laboratories. So there is a ballpark of things that, of course, if you're going to run a laboratory and produce diagnostic results for people to be able to live on, to be able to get treatment, to be able to determine if they're going to be in quarantine or in isolation for 14 to 21 days, we need to think about their regulations in countries. So different countries have come up with guidelines on how to manage COVID-19. There are standard operating procedures, commonly called SOPs, that laboratories have adopted for different kits, for different testing methodologies. Then, of course, there is a bunch of equipments that are out there that could be used either for viral testing or for serological testing. And then those equipments need to have a service manual that ensures that the operators of the manual are actually well-schooled, well-trained, and competent to be able to use this equipment. Then, of course, there are test articles, there are reference books, which operators need to be very conversant with. Why? Because it allows them to be able to make intelligent decisions about the results that they get for their different patients. So talking about ISO 15189, ISO 15189, the standard for medical laboratories, is actually divided into 7 different sections. There is a scope section. There is a section that talks about normative references, all the requirements, requirements that are needed to be able to execute the standard. There are terms and definitions. And then there are these 2 sections which are most known of, the management requirements and the technical requirements. So just looking at the management requirements, this is everything that a laboratory needs to make sure that they actually have in place to be able to say, yes, we have a good management system that allows us to be able to run testing. So I'm just going to spend a few minutes and go through all of them. It talks about the organization and management responsibility. When we're talking about the organization, it has to be clearly a laboratory with the authority to do testing. That laboratory with the authority to do testing, it has to be a legal entity, would have a system that defines how it's going to receive samples, how it's going to test those samples, and how it's going to send out results. There are going to be documents. We spoke about standard operating procedures a few seconds earlier. And then, of course, service agreements. There are going to be equipment that are going to be used. there is the building itself, the air conditioning in the building. Those are things that need to have service agreements. But also there is the service agreement, which is very important to note. That is the contract between the laboratory and the patients that they are going to see. Then examination by referral lab. The COVID-19 test was done in one laboratory and they're not comfortable with the results that they have. Yes, they should be able to send it to another laboratory, preferably a reference laboratory, to be able to repeat the test. Then there are external services and supplies we need to run the lab. So there are other things that we're going to need, something as simple as paper to be able to produce results. That is important, ink to run the printers. So we're going to have external services to that extent. Sometimes I talk about some things as simple as the electricity. Electricity is a very, very important thing to ensure that our equipment stay running. Water, there are requirements for water to be able to use water for running our test. Then advisory services, what are our lab directors going to be interacting with the rest of the clinical bodies? What kind of information would they be giving them? Resolution of complaints, this is a very important piece because all our clients may make comments and those comments might actually translate to a complaint, a dissatisfaction on their part. And those complaints need to be registered and there is a need for the lab to be able to come up with a resolution to those complaints, document the resolution, and then execute the resolution. Identification and control of non-conformities. Happens, there are generally standard operating procedures that have to be used. There is as well the standard ISO 15189. There are country regulations that have to be put into play. And in some cases, there are accrediting body requirements. If the testing laboratory is an accredited institution, then there are accrediting body requirements. And when all these requirements are not met, or when some of them are not met, then there is a need to identify why it was not met, and then to go on to have corrective action. And in some cases, sometimes have preventive actions that stop non-conformances from occurring. Then, of course, because we're in an age where things are continuously changing, there has to be an element of continual improvement. Basically, how do we move on to the next technology that exists? How are we going to be able to reduce the turnaround time for giving out results? How are we going to increase the sensitivity of our test? How are we going to ensure that our patients get the right test results for the test that they do? So that's all in the element of continual improvement. And then control of records. Control of records is important because the element of the confidentiality of our clients comes into play here. We want to be able to ensure that all records are kept so that at any point, 2 years from now, and we're doing a study on what happened with COVID-19 and how the different laboratories tested, we can now go back to records, which will be the results that were issued. And at this point, be able to have a discussion on what is going on for research purposes or just for evaluation purposes. Evaluation and audits, ensuring that what we set out to do, the methodologies that were intended to be used in running the COVID-19 test, whether it's a viral test or a serological test, that those methodologies were used in the intended fashion. And then, of course, a management review, which generally says the management team has to look into what has been going on. This is a snapshot of a specific space and time in the laboratory's operation to ensure that what was intended is actually what was done and that the system is still as suitable as it needs to be. So that's section 4 of the ISO 15189. And then there is section 5, which is the technical requirement. This is the actual doing of the test. In the actual doing of the test, there are 10 really critical elements that need to be looked at. There is the element of the personnel. Who is doing the testing? What kind of training do they have? What kind of experience do they have? What are their competencies for doing this test? In what environment is the test being done? There are requirements for some of these equipments to be at certain temperatures to be able to run effectively. Can we ensure that those environments are there? Is there a nice break room for the staff? Is there a changing room for the staff? Is there a testing space for the test to actually be conducted. Then there is a huge array of things called equipment, reagents, and consumables. And this is such a huge list of things. But all of these has to be cataloged, and cataloged very specifically, because each lab is going to be required to keep an inventory. Because remember, we spoke about when you look at number 4 here, it says service agreement. Before you go into a service agreement, you have to ensure that you can actually fulfill the agreement. What does fulfilling the agreement mean? It means you said yes to a patient that you can actually conduct a COVID test for them. Once you say yes to them, it means that you are going to have from the proper PPE to don to be able to collect the sample. You're going to be able to have the right equipment. The suppliers would have done maintenance on the equipment. You've done controls to be able to ensure that the results are the results you want to have before you can actually run the test. Then there is the pre-examination procedures. How do you collect the samples? What is the management of the sample? The temperatures in which the samples need to be in? How is the sample going to be transported from collection point to testing point? And then, of course, this is where the real beef is, the examination process. How is the test actually run? That is very important. Then ensuring quality of examination. For you to be able to ensure the quality of examination, you have to have a known result. What do I mean by a known result? A known result is simply what we call in laboratory language a quality control, internal quality control. So with the internal quality control, I know that the positives are going to be positive. So there's almost 100% sensitivity there. So ensuring the quality of examination result means I'm going to ensure that my internal controls actually come out as expected. That would be verification that my methodology actually works. Then there is the post-examination process, which now entails the storage of the samples, storage of material that was used, and then going on to reporting of the results, and then release of the results. And then finally, there is the laboratory management system, which could either be manual or electronic. So in today's age, everybody is going electronic. So you could run the test in the laboratory and instantly the results could now be transferred directly to the clinician, the doctors, to be able to see it without having to be any paperwork involved. On the other hand, there's some places where the laboratory information system does not work. And so they have to go manual, which means they're going to have an actual request form that needs to be filled out, an actual result form that has to be filled out and transported to the requesting doctor. So I want to go down a little bit and look at the 3 phases in testing that are really, really important. And these 3 phases, they're key to be able to appreciate what goes on in getting either a negative result for COVID or a positive result for COVID, regardless of whether you're symptomatic or asymptomatic. So in the first one would be the pre-examination phase. That's phase 1 of the 3 phases. This all is based on the ISO 15189. Again, this is the standard for medical laboratories and in vitro testing in particular. So there is information for patients and users that needs to be available. With COVID, there is going to be no patient, whether symptomatic or asymptomatic, who is going to collect their own sample. So in this case, information would be to suspects to understand what are the symptoms of a COVID infection. Because generally in this case, if it's going to be a blood sample for serological testing, you will need to go to a laboratory for it to be collected. If it's a swab sample, oropharyngeal or nasopharyngeal, you will still need to go to the lab for somebody to insert the swab through your nostrils or into the back of your throat to be able to collect a proper sample. So primary sample collection, this is also ensuring that the person who is collecting the sample is competent at collecting a good sample, because the results that you get at the end is just as important as the sample collection phase. So that is really critical. Instructions for pre-collection activities, the technician who is collecting the sample needs to be very mindful. What does the different instrument require in terms of volume, of the sample that is going to be required, in terms of quality of the sample that is going to be used, in terms of temperature in which it needs to be kept, in terms of time, how long does it need to be between collection and testing. That is very important to be able to know all of that in the pre-examination process. So I spoke about sample transportation. Sample transportation is not only the integrity of the sample leaving from the point of collection to the testing point. Sample transportation also has public health consequences. So that has to be a city to the next end of your city with a COVID-19 sample that is not properly packaged for transportation. What if it gets spilled? How many more people are going to now be infected with the virus? So there is a whole mechanism, there's a whole system around transportation, methodology for packaging before transportation, and then there is a requirement for sample reception as you get to the point of testing. And how is that going to be handled? How is the sample going to be handled, and who is going to handle it, and what are the requirements for handling it? I actually bring in this part of the standard just a little earlier before we actually go into the actual examination phase, because ensuring the quality of examination is very, very important. If you don't ensure the quality of the examination, then there is no way that you could actually say for certain that the results that you produce are what they are. This is regardless of whether they are negative results or positive results. So before you start testing, in the case of COVID-19, if you're going to be doing a PCR, you don't have the luxury to be able to just run controls. You're going to be using a 96 well plate, for example. And if you're going to use a 96 well plate, you can't just run a 96 well plate for 4 hours to be able to get controls. So you put on your controls and your patient samples on the same well, and the same plate, sorry. And when you're on the same plate, then you now run them. So the quality control basically asks a very simple question. Are the results of the patients, are they valid? And basically, for us to be able to answer that very simple question, we need to have quality control material that basically say the quality control material, first and foremost, must mimic the patient sample. So it must look in terms of ingredients like the patient sample, because it is going to be reporting what the patient sample should actually be reporting. So the quality control material basically would allow you to say, should the quality control material be positive, it means any other slide, any other patient on that 96 well that shows the same reactions like the quality control would also be positive. So if you're using the PCR and then it has coloration, so there is a change in color. So if your controls suddenly became yellow, and then you found in any of the other wells a yellow sample, it means that sample has responded like your positive control, therefore saying that that sample is positive. Your negative controls will be clear. If your negative control is clear, any other sample in any of the wells that comes out clear is going to be deemed as negative. So literally, the quality control becomes really crucial, because you are actually saying this is the standard and everything else is compared to the standard to be able to determine what that result is going to be. So while we're doing quality controls and ensuring the quality of the examination, there is inter-laboratory comparison. So we're dealing with a new virus. We're also dealing in a situation where we're using emergency use authorization to run a lot of the tests. So it becomes really important that amongst the labs in any country, if you had a country with 2-3 laboratories that are running COVID-19 tests, it becomes really important that every couple of weeks, say for example 6 weeks, they could select a number of samples and share amongst themselves and then run them to ensure that they get the same results. Because in so doing, they will be ensuring the competencies of their laboratories, but most importantly, they will be ensuring that the results that were actually given to the suspects at the different points were actually reliable results, could be repeated, could be tested, and always could be confirmed. So participation in interlaboratory comparison is very key especially at a point like this where we're using EUA kits. That becomes very important. Alternative approaches to interlaboratory comparisons are important. You could have blinded samples and have your competent scientists run them. That would be a good approach as well. Analysis of what is going on in the different laboratories. How far from the mark is your competing laboratory or your interlaboratory laboratory? Evaluation of the that allows them to be able to compare their results. So you would, if you're going to use a specific manufacturer's platform or a specific series of the platform, it becomes really important that the laboratory with whom you're going to go into interlaboratory comparison is also using the same series of that platform. I'm trying to be very careful. I don't want to call any manufacturer by name that look like I'm endorsing any of them, which I'm not intending to do today, at least today. I haven't gotten my paycheck yet, so when I get it, then I'll do the endorsements then. Comparability of the examinations. This is done to ensure, prior to going into, once there is an accepted criteria between the laboratories that are going to do interlaboratory comparison, once now you get results, using the accepted criteria, you can now do comparability of the examination results. It is very important to note when we're looking at the PCR technology is going to give you quantities and huge replications to be able to say the virus is present. When you're looking at the serological testing, what you actually get is a qualitative result. It just says positive or negative. There is a bar on the cartridge that tells you it's positive or negative. But then we need to be able to have an acceptable criteria to be able to do comparability. So let me go back one now to section clause 5 of the examination process. And in the examination process, this is where, as I said earlier, this is the real meat of the standard. This is the actual doing of the test. So you have to actually select a methodology to use. That methodology has to have had verification. Basically, a test that actually says what the manufacturer said was going to happen actually happens. So there is a known result given to you by the manufacturer. And then you do some in-house test and you verify, just like the word, you verify that what the manufacturer said you were going to get is what you got. Should you have to use the manufacturer's instructions out of its intended use, then at this point, you're going to have to do a validation study. Because if the manufacturer said, you can only use my equipment to do serological testing, you're going to have to collect blood to do this. And now all of a sudden, you're now going to use urine. Because the manufacturer had not validated urine at the time of manufacturing, and you now want to use urine for COVID testing, you will have to do a validation to be able to show that urine could give you the same kinds of results like the serological test or the viral test. That would be the validation of the examination process before you put it into use. So again, verification of the examination, as I just stated, or validation of the examination, ensuring that the intended use could actually be attained, and ensuring that the results that you give actually they meet the sensitivity or the specificity as the manufacturer had said. Then there is the element of measurement uncertainty. This is very important. Measurement uncertainty actually looks at what is the measurable volume that could cause a false positive or a false negative. This is very important to note. The measurement uncertainty of every test that has a measurement involved, set 50 microliters, or you are going to weigh 0.05, and if that measurement actually is supposed to be, then there is a measurement uncertainty, and the addition of your measurement uncertainties between a weighed volume and in a result that is false negative or false positive. So knowing what your measurement on a known result, let's say, for example, for a young lady, 25 years of age is supposed to be 13. We could say the measurement uncertainty for her hemoglobin is going to be 13 plus or minus 2, which means if we had a result 50, that is acceptable. But if we had a result at 10 or a result at 16, then now we know that we have a problem going on. The measurement uncertainty of us collecting the right volume, of the right pipetting happen, might have gone into play. Then we move on to have a reference interval at that moment. So a positive result is going to be a positive result for vaccines, because countries and different groups of nations, East Africa, West Africa, Europe, the United States, Latin America, they're all going to work on their vaccines based on what, of course, documentation of the examination procedure. This basically allows us to document the fact that the examination was done step by step as was expected to be done. So the results that we actually get are going to be results that we expect to see. So this is documenting the examination process is pretty crucial and very important to ensure that should anybody come later on and they want to review what we did, they have information enough to be able to say, these are the steps that were followed, and this is the result that was gotten. This is most probably the shortest part of a very important process. This is actually just getting the examination results out, the post-examination process. So somebody reviews the results, whatever samples are left go into storage, whatever key material is left goes into proper storage. Retention, creating a biobank to be able to store the samples. This is huge potential for research down the line. Retention, disposal of everything that was used, ensuring that the medical waste is properly treated. In this case, we're dealing with COVID-19. COVID-19 at the very minimum needs a biosafety level cabinet 2 for us to be able to conduct the initial testing with. So there is a lot of things that need to be looked into as we go into that. This is a slide that looks a little bit busy, but this is a slide that actually brings together a number of the clauses out of the ISO 15189, and it looks at evaluation and audit, some of the things you need to do there. You need to carry out an internal audit. You need to look at what are the indicators that you've set for your system to be able to say you're running an effective and efficient system. External auditors, did you bring in somebody to do We're talking about interlaboratory comparison. An authoritative body to come and audit your systems to ensure that what you're doing is actually acceptable. Then there is examination results. But what is important, all things that happen in the standard, just go through those two funnels. And as they go through those two funnels, we actually get a chance to understand what is going on with our system, and then we make improvements to our system. So we go down to clause 4.12, which talks about continual improvement, which basically comes out of three very crucial parts of the standard, which are all based, very interestingly enough, they're based on the management side of the standard. 4.9 talks about identification and control of non-conformities. 4.10 says, now that you've identified some non-conformities, what is the corrective action you're going to take? Now that you know what your non-conformities are, now that you know what risk might be inherent in your system or what risk your system potentially has, what are the preventive actions that you're going to take? Collectively, looking at these elements out of the management section of the standard allows us to be able to do some continual improvement, which therefore enhances the technical requirements into running a proper COVID-19 test. So I throw in this slide because this slide basically tells us about some of the accrediting bodies that are out there that allow laboratories conformity assessment bodies that want to say, yes, I'm accredited to ISO 15189 to use these bodies for their accreditation. Just as I close, I like to throw in this slide. It's a very simple slide. It has been said over and over and over, hand washing is important. We need to wash our hands with running water and soap. And running water and soap can be gotten anywhere. It doesn't that is involved in this. It's very simple technology. There is a gallon, there is a stick which acts as a pedal, and when you step on the stick, and there you have running water. Next to it, this is something that has become very familiar in a lot of places. You have a bucket, and you fix a tap to the bucket, and there's a nice basin below it that now collects the water as it runs out. And in both cases, you would be very effectively washing your hands, which is a very big requirement in ensuring that we stop the spread of COVID-19, washing of your hands. We now come to know very familiar the temperature gun. It's a very basic entry point into knowing whether you're transitioning from asymptomatic to symptomatic. Washing of hands, we just saw the nice picture on washing of hands. In the absence of being able to wash your hands, sanitize, sanitize, sanitize. And then, of course, we'll have a good face wear that protects any of the particles from coming onto your eyes, nostrils, or mouth. And again, I must say that these four things together are not in and of themselves a panacea to ensuring the fact that you will not contract coronavirus. We have to also throw in social distancing. Wash your hands, have a face wear, sanitize, but still we need to ensure that there is a reasonable social distancing that is kept between ourselves and anybody else. Then of course we have the vulnerable population that we also need to look out for. So with this, this is our look at the standard ISO 15189 directly required for the use of testing, and this is a requirement for testing with COVID-19. At this point, I'm going to stop and entertain a couple of comments, questions, some suggestions. This is now participant time. Thank you. So please just raise your hand if you want to say something. If you just raise your hand, I would be very excited to call you and have a chat with you. Or if you have a comment, you could just go into the chat box and write out what you want, and I should be able to reply. Okay, do we have? Ooh, that's a nice long one. How can we ensure investment in prevention and public remains a permanent action for all? Oops, sorry. For all epidemics and future governments, other than use having emergency appeals for funding? I think that's a very, very important question, and that's a good one. Thank you so much for raising it. I think one of the things that all governments are doing right now, there is huge funding coming out for COVID, whether it's coming from the World Bank, from the Global Fund, from our partners. What governments are trying to do is we're trying to build systems now that are not only going to respond to this pandemic, but are going to be able to respond to future epidemics that are good. So we need to have structures all across. So we want to have structures from national level to the next tier down, all the way to district or even lower levels. So basically what we are looking at is how does a government actually build structures that are going to be able to last after this pandemic. That will be the key to ensuring that with future pandemics or future epidemics, we would already have a system, we would have a response mechanism that works and works efficiently, but most importantly, works immediately. Okay. How can we, so, for the case of Uganda, when we had only one lab doing COVID testing, was internal quality control possible? If yes, how was it possible? Oh yeah, if you think about the case of Uganda, and it's not only Uganda, when the pandemic broke on the continent of Africa in March of 2020, on the continent of Africa, it was projected that there were only 2 laboratories that were ready and capable to test for COVID-19. And within another few weeks, we moved from 2 countries that were ready to test for COVID to 44 countries in less than 6 weeks that were ready to be able to test for COVID. What happened? In the case of Uganda, coming out of Senegal, Institut Dante in Senegal has panels which they were distributing for all COVID testing facilities to be able to use as internal control. And in the case of Uganda, which I happen to have some knowledge about, the Uganda Virus Research Institute is now, with the other labs coming on board, process goes on, is now able to produce, to be able to ensure that there is quality control going on. So the case of quality control has been there from the, so the issue of quality control has been there from the word go. There have been labs that are out there that were having panels. And as I said, Institut Dante out of Senegal had panels. And so UVRI has been using internal quality controls. And so are all the other labs that are doing testing in Uganda. Next question. With these mobile labs set up at border points, ISO 9001 met since they are usually set up at border patrol points, which were not met biosafety. Oh no. So one of the requirements for the mobile lab to actually be stationed at any place is it must meet the most basic conditions. And one of them is ensuring that there is a biosafety lab, biosafety cabinet too. So the mobile lab is actually not as mobile as you think. So there is a van that drives the instruments to wherever it's going to go to. It gets packed there, and then the actual instruments are placed in a laboratory in that area. So for the case of Uganda, I know you're referring to the mobile vans in Uganda. There is one based at Adjumani, and there is one based in Tororo. And when you, these are labs, in the case of Tororo, that's a lab that is well on its way to accreditation. Jimani is a lab that has gone through a very robust quality management system. So they actually meet the biosafety requirements for testing. So in this case, yes, the 9001, I would not say that the 9001 elements have been implemented to the T, but I'm going to tell you that the elements of the ISO 15189 are actually present to be able to allow for the mobile labs to be stationed wherever they are stationed currently. Thank you. Next one, 4. With landlocked countries, Uganda, Rwanda, having mostly imported cases, is the RO we are reporting applicable to the context or settlement, since most of the cases reported were allowed to freely mix with the population? And also, if they were talking about flattening the curve, we even have a curve of the case of Uganda. Their onset, for most of the African countries, the onset of the virus in the country was actually imported, which means that people flowing, nationals flew back home, and in flying back home, they actually brought the virus with them. So there are 4 phases to the virus. There is a case 0, then there are sporadic cases, then there are clusters, and then there is community infection. So in the case of Uganda, again, which you are referring to, we've moved right now, we consider Uganda to be in a cluster situation. So when you're talking about the clusters of Uganda, yes, you're right. We're looking at all the points of entries. If you look at the map today, it's a Legu, it's a Malaba, it's a Meticula. It's most of those ones that you actually see. But again, we also have a few cases. We have a few cases in Kampala. We have a few cases in Barara. We have a few cases in Masaka. So we still have a few cases that have actually managed to traverse the points of entry. So when we also look at the reproductive number, the R number as is known, in the case of Uganda, for the amount of testing that we're doing, and right now we're close to almost 90,000 tests that have been done. And when you look at the amount of tests that have been done for 770 positive cases, that tells you that we're doing an enormous amount of testing compared to any of our neighbors, Rwanda, Tanzania, Kenya, or any of the neighbors. So flattening of the curve for Uganda is very possible. So we're going to identify positive people over a longer period, and it's also going to be very correlated with the lifting of the lockdown. So we still have a bunch of different sectors that have not been lifted. But what that does is it allows for our healthcare systems to be able to accommodate the positive cases as they get found, which is very important. So when we talk about, are we going to be able to flatten the curve in Uganda? If flattening of the curve relates to how do we continue to ensure that we have positive cases, yet we have a healthcare system that can actually accommodate them, then my answer to you is yes. In the case of Uganda, I think I have flattened the curve. Okay. Any more questions, comments? I have 5 more minutes. If anybody has anything to add, anything you want to bring to our attention, we'll be very glad. Or if somebody wants to make a comment, just raise your hand and I'll be very happy to call you. It's always nice to have somebody else speaking other than just myself. Again, as I say, this would be, our slides will be available for you on our site in about another 48 hours or thereafter, or you could contact us. And I left both all our contact details, our info at the Global HF, our landline, a phone number to reach us. You could reach us on Facebook, you could reach us on the web, and of course, you could actually come and visit us in Kololo if you're around Uganda and Kampala. Okay. I bet this must have gone as well as it was going to go. I thank you all for coming. I thank you for listening, and I thank you for participating. Please, this is Monday. We have one more Monday in June, and it will be the end of the first half of the year. I wish you well. Go out, be safe, wash your hands, sanitize, have a good, nice face wear, 3 layers, and still continue to maintain your social distancing. See you next week, same time, same place. Thank you.